Great, thank you for that. As was just said, that was incredibly inspiring and also impossible to follow. So I'm not sure what else I can say. What I would say up front, I suppose, is that I guess I'm an adult neurosurgeon with a specialist interest in neuro-oncology, looking after people with brain tumors. But I can totally empathize with the points that Hannah was making there, having just realized myself that I spent 3 weeks when I was just turned 17 on an adult ward, having had some significant surgery myself, and I totally can relate to the experiences that Hannah has just described to us so beautifully. I'd like to talk a little bit today about shared decision making. Really, I'm coming at this from a very personal perspective, my own journey, I suppose, in this area, and a few thoughts for how we might want to take that forward in the future, both locally and possibly nationally. So just to put this in context, shared decision making is a key and important part of the personalized care agenda, which is first and foremost, I think, in the minds of everyone from provider to commissioning level at present. There's some really nice information on the NHS England website if people are interested, but what is personalised care? And what that means to me, I suppose, is that focus on giving patients and empowering patients to have that choice and control over their own health. And that really relates back to what Hannah was saying there. It's really important, that thing about choice and control, both physical and mental health. And NHS England describes 6 programmes of work at the moment that are being embedded to support that process. And shared decision making is one of those 6 pillars, if you like, and something that I'll just focus on today because I believe a really important component of that agenda. So what does this really mean to me? And I think, there's quite a lot in that first sentence on the screen there, that this is really shared decision making, an honest conversation about reasonable competing options. Seems like a simple statement, but there's a lot of information contained in that statement. The honest and open conversation. I think as doctors in the past, we haven't always been as honest and open with our patients as we might have been. And there's a shift in that focus. The other thing that's often confused about shared decision making is that this is about simply presenting people with every option that might be available for their particular healthcare needs. And that isn't the case. This is about reasonable competing options. But importantly, and again, relating this back to Hannah's talk, this whole process recognises that there are 2 experts in the room during a meeting. The clinical expert, who is of course able to give the information on those reasonable options, the pros and cons, the risks and benefits, but very importantly, and just as importantly, the patient, or the patient and their family. And the patient and the family obviously arrive at that consultation, don't they, with their own experiences, views, preferences, values and beliefs. And the shift then, the emphasis has really shifted now from that conversation about what is the matter with you to what matters most to you. And it's quite a skill, I would say, for a clinician to have changed that mindset themselves to extract that information from a patient. And I'll give you some examples of where I've got that wrong and where I've maybe got that right in due course. Another important component of this, and again, Hannah actually touched on this in a sense, is that we should be supporting these conversations with evidence-based information. But importantly, that information needs to be given and available to patients in different formats. It may be verbal, it may be written, it may be visual, it may be video, but it has to be something that can be accessed by patients of different ages, different backgrounds, different reading ages, and so forth. So I think there are many advantages to running a shared decision-making way of working. I should say up front that everyone thinks that they do this, but if you ask patients whether they think their consultants or their medical teams are doing this well, they often tell you that they're not. So I think there's a discrepancy there that we need to be honest and recognise. One of the issues, and I mentioned about being honest and open, is that there's very well described evidence that clinicians and patients actually tend to overestimate the benefits of a treatment and underestimate harm. And of course, if you do that, it might well be that you end up making a decision that isn't actually the right decision for you as a patient. One of the reasons commissioners like this, as well as healthcare providers sometimes, is of course there is a possibility that using shared decision making effectively may actually reduce unwarranted variation and actually allow us to allocate resources to those that actually want and as well as need the treatments that we're prescribing. There's very good evidence as well that and I'll show you some of this, that patient satisfaction, outcomes and safety, all of these aspects are improved. And I think in the post-Montgomery era, there's pretty clear evidence that this is the right thing to do in terms of complaints and litigation too. So just briefly, we introduced this into our practice a few years ago. I won't say a lot about the details, but I had some training in shared decision making myself. I, like many people, thought I already do this, I'm already good at it, until I was trained in it and realized that you can always be better at everything you do. And that was the case here. It really shifted my mindset in how I hold these conversations with patients. We developed some decision support tools, which are just information sheets to support those conversations. I would say that's an important, but not the most important part of this process. And many of my patients, unfortunately, are dealing with incurable cancers, and these are often quite difficult conversations, but they often have choices to make, quite frequently 3 choices that they would have to make. We did some provisional analyses when we'd introduced this. We asked that both the clinicians involved in the team and the patients themselves what they thought of the consultations and the process, and we have a bit of data on that. You don't need to look at all the detail on this slide, but really just to emphasize, this was a decision grid, and this is written for adult patients. It's really hard to write this in a way that is accessible to everyone, I have to say, although we have some charities input into this. The importance about this is not the detail in this slide, but just to say that across the top there are the 3 options that we might offer to a patient. And on the left-hand side, some sort of frequently asked questions. You know, what are the pros? What are the cons? Who does this work well for? What are the risks? Those sorts of things. So it really frames the discussion we might have in an outpatient consultation. So when we asked our staff, we used a questionnaire called the AQUA questionnaire, what they thought about shared decision-making both before and after. And what you can see, very brief summary of that, is that actually in every domain, we showed that after the introduction of SDM, that the staff attitudes to that process significantly improved. We used a questionnaire for patients, one that we were recommended to use, Collaborate questionnaire. You can see here that that consists of only 3 questions, but those questions focus on, as you can see, how much effort was made to help you understand your health issues, how much effort was made to listen to the things that matter most to you about your health issues, and how much effort was made to include what matters most to you in choosing what to do next. Now, whilst they're really important questions, what I would say, and I've said in red there, that there are other tools available, is I didn't find this a very sensitive tool. And I would say if you're someone who develops a very good rapport with your patients and gets on with them well, whichever tool and whichever questions you ask them, they'll most likely score quite highly. I say that because there's a preempt to this really, and you'll see these graphs with a sort of before and after. And one thing you can see before and after, the patients scored incredibly highly on this questionnaire. So they did feel very involved in their decision making. It did increase in every domain, but quite slightly. In fairness, not only was the questionnaire not terribly sensitive, but we'd already started on a journey really before we started some baseline data. But Collaborate may not be the best tool to use in this context, would be my learning. I'd just like to tell a very brief story, if I may, about my own journey with 3 patients over, you can see, almost 15 years now, looking back. And this is 3 patients with the same diagnosis. They sadly had malignant primary brain tumors called a glioblastoma. And 13 years ago, so I've been a consultant for about 2 years at that stage, I had a patient who was in his 60s. He came to the clinic on his own. He had, it was quite obvious, had a glioblastoma. It was operable, it was treatable. And I presented my opinion to the patient about what this was. I should say he was a guy who ran his own business. He lived alone. That I knew about him. More than that, I didn't know about him. And when I explained the options to him, I said that the MDT had advised he should have an operation to remove this, and this would give him the best outcome and would be the best evidence-based treatment for his condition. I did explain to him that, of course, there were other options, including a biopsy or just to have some supportive or palliative care, but that, you know, surgery was the recommended option. And there's just a way of framing that conversation. I think you can see where I'm coming from, that may not have been optimal at the time. And he said, well, thank you very much for telling me that, Mr. Grundy. I don't think I'll have any treatment at all. And he shook my hand and left the room. And I must admit, quite taken aback at the time, because I'd never had a patient refuse to have treatment. I thought, quite honestly, this is crazy. He's going to die in the next few weeks without treatment. And I really, really struggled with this. In fact, I phoned him at home a couple of days later, not something I don't spend a lot of time phoning patients at home, but I did phone him at home, and I just wanted to talk it through with him again to check that he'd made the right decision. And all he could say to me, both in the consultation actually and afterwards, was, look, I have my tax return to do. It's a very busy time for me. I haven't really got time for this. And I just need to be left to finish this up. Thank you very much. Again, I thought, this guy is crazy. He's not being rational. So I phoned his GP. I'm getting really desperate now. I'm phoning his GP, and his GP, of course, went to see him and then phoned me back the next day. And he said, well, I've spoken to him. I've been over the conversation. He's made the right decision for himself. He said that what you hadn't perhaps realized, because he didn't tell you, actually I didn't ask, was his father had had a cancer and had a really bad time with treatment. He didn't want that. Not only that, I think the thing about his obsession with his tax return was really he was getting his affairs into order. That's what he was doing. And it was just completely lost on me, because I hadn't really got to know what he was about. So, you know, I really reflected on that, and I learned from that. Now, forward a few years, and I wouldn't have the same conversation now, but we started the SDM process, had another patient in a very similar situation, but he attended the clinic with his wife. I explained the options, but in a different way now, explaining the natural history of the disease, explaining that all of the options were reasonable and rational competing options. After all, this is an incurable tumor that, despite our best efforts, would likely result in a very short life expectancy. And again, on this occasion, the patient said, thank you very much. I don't think I'll have any treatment. And he had a bit of a cry with his wife, and he left the room. And as he left the room, my clinical nurse specialist said to me, this is crazy. You can't let him go. He needs to have an operation. And I guess I'd come to terms with the fact that, you know, he'd made the right decision for him with his background and his experiences. But at that stage, she definitely hadn't. And that was really, really eye-opening for me. And obviously, given that same information, she had processed that, you know, you must have an operation, you must stay alive. That's what she felt would be right for her. But that wasn't what was right for him. So I guess we then went on a bit further of a journey as a team together. And this really was a team effort. And that takes us up to about a year ago, because all of my colleagues now are trained in these techniques. And my senior fellow met a patient, a very sad story. He's in his late 30s. He presented to the clinic with a weakness on the right-hand side. And actually that weakness had not improved with steroids. And he came to the clinic, and same conversation with my fellow, explained what the scans were showing. She asked, you know, she got to know this chap. What do you do for a living? Turned out he worked in a security team at festivals. And he quite enjoyed that role, because it gave him some opportunities. I have to say, opportunities with the ladies at festivals. And he was quite successful, because his other main passion was he was a bit of a bodybuilder. He really liked to work out in the gym. He had one other passion she asked him about, and his other passion was he liked to drive a sports car that he used to do up, and he would drive, and he was very proud of this car. In fact, those were his three passions in life. And he asked my fellow, well, look, I've got this weakness. I've been told now I can't drive. Will I be able to drive again? She said, I'm sorry, you won't. Will I be able to do my job again and train in the gym as I could before? And she said, I'm sorry, I don't think you will. We will be able to give you some treatment. We can keep you alive, but we can't make you any better. And he then made a decision, well, if that's the case, that's not the right treatment for me. On this occasion, I suppose what was really different was that he'd obviously made the right decision for him. My fellow was very comfortable with that. I was very comfortable with that, as was our CNS. And what we were able to provide for him was the support that he required in making that decision for himself. So you can see we've gone on a real journey, and I think that's what this is all about. So very, very briefly, we found it actually to be a really beneficial and rewarding process ourselves. I think our patients, as you've seen, have reported very high levels of satisfaction too. I would say that questionnaire that we used wasn't desperately useful. It does take a bit of time to do this properly. So we've increased the amount of time we spend with our patients because we think this is such important and such valuable time. So we spend 50 minutes seeing a new patient now. We have the luxury of that at least. I'd rather do more clinics and give people a bit more time than try and rush them through. You can't with difficult conversations like this. What we don't know, and what the commissioners liked about this, was they had figured that if we had these conversations and really worked through with patients what treatment they may want, there's good evidence that fewer patients choose that really complex, high-risk intervention that actually, from a commissioning perspective, is also very expensive. What we don't know is how much impact that's had, but you can see from the examples I've given that there's no doubt this has some impact, I would say, in a small number of patients in terms of them choosing a less invasive option. I do really think this is a standard of care following the Montgomery outcome in 2015. And just leading back into Arvind now, what I would say is that we've got a piece of work now, and Arvind is involved in this, that is about implementing this way of working, I suppose, across our whole system. And part of that, as we'll come on to, is about preparing the public and the staff for that process. And I'll show you the R3 questions in a second. But the other part of that is about leadership, is about developing resources and support, about training our teams, training champions, and then redesigning our pathways to incorporate that. And that's a journey that we're on as an organisation at present. And the R3,
thank you, Charlotte.
The R3 questions
that
Arvind has
just
so wonderfully introduced across the organisation for us, illustrated here. Someone's talking, I don't know if that could just go on mute. And really this summarises the whole process very beautifully, and Arvind has done fantastic work with the team on having hopefully having a good representation of both staff members and patients in this diagram, because we have to recognise that we all have different needs. But these are the three questions. They're very obvious. I've just talked through them just now, but this is the framework in your mind. And importantly, at the bottom there, as it says, your healthcare team needs you to tell them what is important to you. And finally, just to finish up, and I think this again, reflecting back to what Hannah said before about patient feedback and how we would like to be seen, I suppose, if we're getting this right. And I'm not sharing this because to kind of make myself look good, because all the credit for this really positive piece of feedback that I will share is absolutely owed to my team and not to me. In that this was from a patient who had, again, a malignant brain tumor, needed a complex operation. He was seen on the ward by my registrar with the CNS. He was then seen back in the clinic by my fellow the week later, and I only met him on the morning of surgery. So all of the conversations that had gone on had been the CNS, my team, and the patient and the family. But this is what they had to say, and they posted this on Facebook to me. I think for me, it's the second part of that first sentence that's the important piece here. Just to read that, it's truly humbling to watch them put the patient so firmly at the center of every single decision they make and all they do. And I guess that's what it's all about. Thank you.
Oh, I have to say that really does summarize shared decision making and putting the patient at the center of everything. And again, I think I'm going to be in tears by the end of this talk, by the end of this day. Going back to what Hannah was talking about, it doesn't make any difference. It's whether you're young, whether you're old, whether you're a parent or a carer, you want to be involved with those decisions and know that your voices are being heard. So, Kath, are there any questions from that? Or shall I lead on to the R3 questions? But let's see if there's any questions. Because Paul, do you have to go?
I can stay until past.
Oh, perfect. Okay. Well, in that case, shall I go on to the Ask Three questions, and then we can take questions together? And Paul has been instrumental in actually getting us all together, and actually providing fantastic leadership and with a great team, so that we've actually developed the Ask Three questions that allows us to frame the shared decision making and put it on the table so patients have a voice, and it's really important. James, are you able to share the screen for me? Thank you. So, and one of the reasons this is really important, and it brings it home to me, and sometimes one of the reasons I'm passionate about it, when I went to talk about Ready, Steady, Go elsewhere, not here, but in another hospital, but it doesn't matter, I'm sure it's the same wherever you go. There was a 6, 17, 18-year-old girl that had crash landed in adult services and was now on dialysis. And she'd been on dialysis for 18 months, but she didn't know anything about her condition. She goes, the doctors are always so busy. She goes, I'm just so grateful to be seen that I don't feel I can ask the questions. And the incredibly sad thing was that her sister crash landed 6 months previously to me going to talk. And they were in a similar situation, no idea what the future held for them. And she said, had this been around for her then, it would have made a huge difference. This and the Ready, Steady, Go program. So let me talk about Ask Three questions. Let's have a look. Can you guys all, I'm hoping you can all see the screen. Paul, will you just wave if you can see that screen? You can be my little wingman, perfect. Okay, so guys, Ask Three questions. Why is it important? Okay, this just shows one of my patients looking at the Ask Three questions, giving it a thumbs up to show that it was co-produced with young people. Don't go anywhere because I might need a mouse. The mouse isn't working. Yeah, the mouse isn't working. Are you able to? Sorry. Okay. So I've got. So why are the three questions important? Because there's lots of research that shows asking people to be involved in decisions about them, they get higher quality, better care, which Paul has just shown, and they choose options that are right for them, and you'll get better adherence to treatment, and the long-term outcomes are better as well. And the Health Foundation were very, very supportive of this. And many of you will probably have heard about the MAGIC program, which is called Making Good Decisions in Collaboration. And you're about liberating the NHS. There was this big document that came out in about 2011, 2012, possibly a little bit earlier than that, called No Decision Without Me, which has been really big on the NHS agenda. But to embed it, next slide, please. But to embed it, you know, making change is incredibly difficult. So the Advanced Quality, the Aqua Group in the north of England, which is a national collaborative and supports about 60 trusts in the north of England, with some more people with other trusts across the UK, were involved in this piece of work that was commissioned by the Department of Health to improve shared decision making. And they came up with the Ask Three questions, which was, what are my options? What are the pros and cons of each option, and who can support me to make the decision that's right for me? And Emma Walker, next slide please, very kindly shared some of the feedback from the project from that time. She was leading on the project. And she said, you know, this is what the team says. It's simple, it's easy, it does what it says on the tin. It doesn't need any explaining, and it's in plain English. And the important thing is we have a question where a patient goes from choices to finally coming to a decision, and it's great benefit to patients and the healthcare professionals. But what did the patients' feedback? Actually, they really like using Ask Three questions. It allowed them to ask the question. If you think about that 19-year-old that crash landed in adult services, and if you think about what Hannah was saying earlier on as well, and Paul, they were able to get more information out of their appointment with their consultant. And even if they didn't get the answers, they felt much happier being allowed to ask those questions, and everybody felt it was a more rounded consultation, and it was a very good way of actually having that consultation. And the patients, which is really key, felt empowered, as did the healthcare professionals. But, and some of you will be aware of this document from 2014. This is one for HIV and TB, but it's across the board. The all parliamentary groups have been involved because they've said for high quality, sustainable healthcare, patient empowerment is key. And part of it is changing the healthcare professionals' behaviour. And that's where shared decision making comes in. So although this has been around and shared decision making has been around since the early 2010s, actually, you know, we know it's good. The Montgomery report that Paul spoke about is still highlighted, and it's highlighted in this report. It's still not happening. So because of this, there's a nice guideline. There's a committee at the moment put together, and they're going to be bringing out a shared decision-making nice guideline that's due out next year to try and address this, to change culture in the NHS. And I'm sure one of the reasons it's very difficult to change culture because the tools aren't always there, and it needs to be healthcare professionals and the patients and carers. Next, please. So luckily, I'm going to be talking about Ready, Steady, Go, which everybody knows I bang on about, but we'll be talking about it later. But Ask 3 Questions and shared decision-making has been in the heart of it right from the start, as you can see from the bottom question in Ready, Steady, Go and Hello. And these were the, this is what comes up with the Ask 3 Questions. The old artwork is there. No decision about me without me again. Really, really keen and important for Ready, Steady, Go. If we go to the next one. But it's very dated. As you could see, you know, you've got old, there's lots of old people, but I like to think of myself as young guys, but there are lots of old people. But things have changed. We don't wear white coats. So with feedback from healthcare professionals, from patients and carers, and also for parity of esteem, we involved the patients, the Foundation for People with Learning Disabilities. We came up with the Ask 3 Questions and adapted it so you can use the same questionnaire across the trust to reduce cost to the NHS and share resources and to have parity of esteem. So this is the one, so the other one we use for the grown-ups and everybody, and this is being used for the young people specifically in the Ready, Steady, Go transition programme. So we think it's great, but we thought this is Nazia, one of our parents, so we wanted feedback from her to see what she said. So let's hear what the patient voice says. A bit louder.
We can't hear that. 1 second.
Sorry. And she's lovely. She's an incredibly dynamic parent who does like to ask lots of questions, but it's about empowering the parents to have it.
It's really clear, and it's very specific about what it is that patients like ask for. So, as a patient, I look at that and I think, oh, actually, you know what? That's perfect, because how do I get the support? And then I know who to ask for, who can guide that decision better. So the healthcare professionals and so on. I think it's really good. It's eye-catching. It's colourful, and it's just really clear. It doesn't go on and on about. You don't have a lot of information to read. It's great. I like it. Dawn.
Yeah, it's the next one. So as you can Nazia, what is really powerful, and the parent says that, and that was pretty poor graphics, but I'm not the best video person. It was on my phone, and I take an opportunity when I can. My husband calls me an opportunist, as does the ex-wife, but we won't talk about that. So basically, I want to say about Ask 3 Questions. What are we going to be doing with that? So we've all bought into it in paediatric and in adult services. But again, having it on its own is not good enough. We need the patients to know. So it's going to be in all patient contact areas. It's going on to all appointment letters. We're sharing it because we believe sharing is caring, and things like this take time. And we want to improve patient experience across the UK, just the way Aqua shared stuff with us. And it's also being translated into other languages for use abroad as well. So how have we used it? What have we done with it? Well, actually, and this goes back to what Hannah was saying, we're putting it up into the Moving On Up Together pathway. So this is where 16-year-olds have a decision about where they move on to adult services. And we'll be talking about that later. We're also talking about renal replacement therapy. And as Anna said, actually, our young people need to have dialysis. This is in kidneys. And they have different options for dialysis. They can have hemodialysis or peritoneal dialysis. But as Hannah says, the resources are full of, apologies, I'll put myself in the old category, old crumbly people like me, okay? That is not what they relate to. So how can we actually meet their needs? So we're going to put our 3 questions at the basis of everything we do, any pathway we make. What are my options? What are the pros and cons of each option? And then we're going to have written material, we're going to have patient voices to make sure from healthcare professionals and the patient voices, so it's a combined pathway that we make. Now, a lot of these things, there's not that much out there to save resources as energy, and also to make sure there's little variation in practice, as Hannah said, so no postcode lottery. We're trying to work together as an association to deliver on this. The same with gastrostomy insertions and medication or diet. Our patients have diet restrictions. Do they want to restrict their diet, or do they want to take medication? So the idea is that we put this in everything that we do, and then we evaluate it, and I'll talk about that later as well. So, next slide, please. So what we're going to do is just poll. I've changed some of the questions, so don't worry about that. We're going to poll, just see what you think about the R3 questions. Do you think that the R3 questions will aid shared decision making? Oh, and if you vote quickly, guys, we will go quicker into the coffee break. We're already running late a little bit, but that's fine. So I'll blame you guys for running 15 minutes late, because this poll is taking forever. Perfect. Okay. Yeah, yippity-doo. Yippity-doo, I like that. Let's look at the next one. So we're changing practice already. What's the next poll that we're going to do? It's just coming up for you. I've combined the next two questions, and the question is, will you start using the R3 questions and take it back to your trust to use? So let's just wait for the question to come up and take it back to your trust to use. So there we go. And if you notice, it's only got the NHS logo on it, so that actually the politics is taken out of it, and you can just start using it anywhere you want. All right, let's end that poll. Fantastic. Have you shared it? That's brilliant. So let's stop sharing. So I think that would say that, yes, we found a resource, working together, we are going to make a change, better for patient experience, and it's changing culture within the NHS. So I think you guys have already spent your £25 very, very well. Now that is the end of the questions. Sorry, that is the end of my session. And if you've got any questions, Kath, I'm going to hand back to you.
I can see that Jenny's actually got a question. Jenny, did you want to put it to Paul? Because I know he needs to whiz off quite shortly. Do you want to unmute yourself if you can?
I think you might have to do it for her.
There we go. Paul, Jenny was asking, you were talking about the questionnaires and how useful or not they actually were. Are there any alternatives that you can recommend?
Yeah, so probably better than the Collaborate is a questionnaire called the SDMQ9, which has 9 questions, and it's about shared decision making, as the name implies. We have tried that in another area, actually, in cardiology, and I think it's a little bit better, but it's still not great. We're actually talking about the UHS at the moment, where we roll this program out to use the SDMQ9, but add some further bespoke questions ourselves that might add more meaning to it, and to try and see how that goes.
That's really helpful. Thanks, Paul. And Janet, you were talking about some work that was currently being tested. Did you actually want to share that? It's still awaiting publication, isn't it? I don't know as to whether you can pop yourself off mute and actually share that work with us.
Yeah, no, it hasn't been right. It's going through the WHO ratification process, so it's going to take a while. But it was a very interesting group of ethicists, adolescent specialists, psychologists, etc., and primarily clinicians, as well as to a tool to very much how you engage specifically young people and assess their development and their developmental stage in how competent and their capacity to make decisions within that shared decision making. So I can share that. I suspect the WHO ratification process takes a while. That's the only problem.
Smashing. Thanks ever so much, Janet. And I know that people have actually been asking for links to all of the resources that have actually been mentioned during the presentations. And there are various links actually coming up in the chat box. But a question really to the organisers, will this actually be pulled together? Arvind, you did say that this was being recorded. So will people be able to access this possibly via the peer network after the event?
Yes, they will be shared with all the delegates so they can look at it later. And all the paperwork that we're talking about today, it's all on the Ready Steady Go website, so people can download it for free. But if people just let us know that they're doing it, so if there's any updates, then we can actually share the updates with them.
Fantastic. Kate, I don't know as to whether you can take yourself off mute as well. You've actually flagged young people with learning disabilities as well, and use of talking mats within your trust. Do you want to tell us a little bit more about that?
Hi, sorry, yeah, I was just replying to someone's question. So the majority of the young people that we work with have education healthcare plans. So we've just been trying to, we noticed that a lot of the feedback from the younger children as well, and the young people, sort of teenagers, was that they didn't really feel like they were involved in as much as their care and decision making. So there was a bit of a project that a colleague led on, and it's resulted in we use a talking map approach to gain young people's views about what they want to work on and support them with decision making at the start of kind of each sort of block of therapy, really, I guess. So for people who aren't familiar with talking maps, it's kind of like pictures and you can rate them into 3 sort of areas, like positives, negatives, something in between. So that's working really well.
Fabulous. That's really, really helpful to flag. And I know earlier on in the chat, as I was just scrolling through, there was a lot of conversation about the appropriateness of young people's units as well. Hannah, paediatrician at King's, I know, has actually developed the King's Outreach Service. Hannah, are you there? Because you've got quite an interesting model at King's. Did you want to share any of that work very briefly?
I am, yes. I've actually put the Chaos Twitter account link on the chat and also been tweeting links. And what we basically did is we didn't have an adolescent unit because there was a big issue around young adults on the adult inpatient wards, and we kind of went to them. So we have a team of about 40 professionals, including neurosurgeons, dermatologists, paediatricians. We've got social work, we've got everybody basically, and have set up a service where the youth workers will go out and see the young people on the adult wards with the support of this big team. But happy to tell more.
Fantastic, and thanks ever so much for sharing all of the links, Hannah. The chat is incredibly vibrant, and there's all of the information actually being shared about the Queen's Nursing Institute transition work that Hannah was so involved with in terms of actually really getting primary care, and our district nursing colleagues on board with that as well. So do have a little look at that link.